Malignancies of the upper airway include cancer of the larynx. This is a malignancy that usually occurs as a tumor in the larynx that's potentially curable if it's detected early. It represents a small percentage of cancers, actually less than 1%, and it does occur about 4 to 8 times more frequently in men than it does in women. Usually it's in the older population around age 50 to 70 years of age, and the most common type of cancer cells that are found in laryngeal cancer are squamous cell carcinoma. It can arise from any of the laryngeal mucous membranes, and cancer of the larynx is sometimes limited to the true vocal cords, but can also metastasize and spread throughout the lymph supply and in other areas and those types of things. The most common symptoms seen with cancer of the larynx include hoarseness, sometimes associated with dysphagia, and also hoarseness longer than 2 weeks should be urged to seek medical treatment because this is a common symptom. Other symptoms include sensation of a lump in the throat, pain in the Adam's apple that radiates to the ear, enlarged cervical lymph nodes, and the patient may also have a chronic type of a cough. The nursing situation for this particular PowerPoint presentation includes MJ, who is a 58-year-old salesman who smokes 2 packs per day for the past 28 years. He consumes approximately 4 to 6 beers per night as he's entertaining clients, and it's noted that he's had a persistent sore throat, hoarseness for the past 2 weeks, and some difficulty swallowing. There are approximately about 10,000 new cases of cancer of the larynx each year, and it causes about 4,200 deaths per year. The risk factors that this particular client has are the fact that he is a cigarette smoker, the fact that he uses alcohol, the fact that he's 58 years old, so he falls into that 50 to 70-year-old category, that's the most common, and the fact that he's a male client, since it is more prevalent in the male population. Additional information that's needed is if that patient had presented with persistent sore throat, which indeed in our case study he did, and if he'd had associated symptoms such as dyspnea, dysphagia, pain or burning in the throat, or swelling in the neck. Many of these patients will complain of pain and burning in the throat when they have hot liquids or citrus juices, things like that, that they take. The other things is the patient may have a very foul odor to the breath due to the cancer, a lump actually noted in the neck. There may be a shift in the trachea, so check to make sure that these patients have the trachea in the midline position. The patient may also note that they've had recent weight loss and pain radiating to the ear if that cancer had metastasized. The surgical procedures to repair this type of cancer include those listed on the slide. Hemilaryngectomy, or the patient may require a subtotal laryngectomy, a total laryngectomy, or if the cancer has indeed metastasized, that patient may need a radical neck dissection to remove all of the cancerous areas that that particular patient has. This is just a slide depicting what a hemilaryngectomy would look like and the areas of the vocal cord and larynx that are actually removed for those clients that have had this procedure done. This slide shows a total laryngectomy where actually the larynx and a portion of the trachea are removed. Please see the readings in your book that deal with care of a patient after a laryngectomy, and those readings are listed in your keynote speaker notes and your syllabus also. For that patient that had had the cancer metastasize, that patient may have to undergo a radical neck dissection, and you can see in this particular case scenario, the surgeon may have to also remove the submandibular salivary gland, sternocleidomastoid muscle, the internal jugular vein, spinal accessory nerves, and it's a very, very extensive surgery. So also includes removal of lymph nodes and those types of things. So that patient may post-op have atrophy of many of the muscles and disfigurement as a due to the radical neck dissection that they've had. Patients that have had metastases may also have to undergo radiation to the area also. And remember, patients undergoing high doses of radiation may have symptoms of ulcerations of the mucous membranes, pain, dry mouth, loss of taste, dysphagia, fatigue, and skin reactions to the radiation. Preoperatively, these patients should be taught that they will have a permanent trach after these procedures. Their breathing will occur then through the trach and not through the mouth and the nose anymore. They will lose their voice because of the extensive surgery and because of the area that it affects. So these patients afterwards will go through speech therapy and need a lot of psychological support. There are several different speech therapy options for these patients, and we're going to talk about those on a later slide. But as you can see, communication is going to be an issue with these patients, as well as disturbed body image, self-esteem issues, and those types of things. The speech patterns that a patient will have after having a laryngectomy done include several different options. One is called esophageal speech, which is where the patient is actually taught to burp up air in order to form their words, and they need to coordinate that movement with articulation and esophageal vocalization. So they work very closely with a speech therapist in order to relearn how to form speech again and that type of a thing. The other option is for the patient to use an electrolarynx, which is a device where the patient actually places this against an opening and that's made after the laryngectomy, and the patient actually in this type of a thing will use this device, which makes the speech then sound like a mechanical robotic almost type of an effect. A third option is the patient can undergo a procedure where they will use transesophageal speech and will have a prosthesis put in with a one-way valve that's opened at the tracheal end and closed at the laryngeal end. And in this type of a valve, when the patient talks, air pressure opens and closes this valve, which permits air to enter the laryngeal pharynx. So when the patient stops talking, the laryngopharyngeal end closes, so the patient doesn't have any saliva or any aspiration issues or anything like that into the trachea. Transesophageal speech is highly successful in probably about 80 to 90% of all patients, and it really resembles normal speech much more closely than either of the other methods that we spoke about earlier on this particular slide. So the only thing is patients that have had this procedure done will not be able to laugh, sing, or whistle. So anything that requires a loud volume and that type of thing, they will not be successful with. Some good calls for nursing for these clients would include knowledge deficit, perhaps related to surgery and post-op care, anxiety, perhaps related to the diagnosis of the cancer and the impending surgery, ineffective airway clearance related to surgical alterations and increased secretions in the trachea, impaired verbal communication related to the edema and removal of the larynx secondary to the surgery, altered nutrition related to dysphagia, and disturbed body image related to the surgery and those types of things. There's also, of course, the risk of infection post-surgical procedure and the risk of bleeding due to the surgical procedure. Typically, these patients don't take in any fluids for about 10 to 14 days after this surgery is done, so they will need to be on NG feedings or TPN and lipids or something like that. The priority nursing response is going to be to, of course, maintain a patent airway. So positioning that patient in a semi-Fowler's or Fowler's position is going to help them and to help keep that airway open. Watch for those patients that maybe are getting into some airway depression. So look for restlessness, labored breathing, apprehension, increased pulse rate, which could indicate some respiratory problems in that patient post-op. The patient will need to participate in coughing and deep breathing exercises, and also will need suctioned quite a bit after the surgery initially. The patient will have a lot of secretions from the trach initially post-op. So Make sure that you're using 100% oxygen to pre-oxygenate before suctioning these patients. And also make sure that they're getting good stomal care. So using protocol for the hospital agency that your patient is at. Humidification will probably be needed initially until the body adjusts to this new airway. And so typically the patients have a trach collar, and which is also known as a concha, put on around the trach to help with these issues. They'll be getting up for early ambulation and activity to help prevent atelectasis and pneumonia. And for pain control, they will need to have some sort of pain meds to keep them comfortable, but we don't want them to get too much because we don't want to depress their respiration. So you kind of have to use judicious use of pain medications. They will have some sort of a wound drainage system in initially to remove fluid from the surgical site. So typically when that drainage starts to wind down, where the patient has maybe less than 50 milliliters or less per day, then they can go ahead and take that Jackson Pratt or whatever type of drainage system that they used out. Typically 3 to 6 weeks after the surgery, the laryngectomy tube can be removed, and then that patient will just have a permanent hole that will be noted in the front of their neck and that type of a thing. So the laryngectomy tube is a little bit different than a typical tracheostomy tube. Most laryngectomy tubes are a little bit shorter and wider than the tracheostomy tubes that you've seen on your patients you've cared for in the ICU settings. To promote adequate nutrition, these patients, like we said, will not have any fluids or food for about 10 to 14 days after having their laryngectomy surgery. So tube feedings will be needed, or lipids hyperal. So make sure that patient also knows that once they do resume fluids, they may need thicket added to their fluids initially until they can get back their swallowing ability and those types of things. Sweet foods may also increase salivation, so they might be taught to avoid a lot of sweets. And they will have a diminished sense of taste and smell due to the pathway being changed. There's no longer that pathway from the nose and the mouth to the olfactory area, so that's not going to be prevalent like it was before. So as part of the nutritional assessment, the patients need to be watched for accurate eyes and O's and weights and those types of things. Some complications that can occur after a laryngectomy would include respiratory distress. That patient may get hypoxic, especially if they have edema or a mucus plug around that tracheal area. So watch for restlessness, irritation, agitation, confusion, tachypnea, use of accessory muscles, and decreased O2 sats on these patients. Also, there's the risk of bleeding from the surgical site, because if you think of the area that surgeon is working on, it's near the jugular veins and those types of things. So notify the physician immediately if that patient does have a hematoma or active bleeding, anything like that. If for some reason that patient would begin hemorrhaging, you would want to apply direct pressure over the carotid artery. Obviously get assistance and monitor for signs and symptoms of shock with that patient, which would include low blood pressure, increased pulse, and changes in respirations, rapid breathing, that type of a thing. Patient, if they were shocky, also would look cool, clammy skin, pale, and that could indicate that the patient was bleeding out. Post-op infection is an issue, so watch for elevations in temperature, changes in the wound drainage, redness or tenderness around the surgical site, foul odor, all those types of things. In addition, discharge teaching should teach tracheostomy and stoma care to keep the area clean and dry, to keep the air humidified, to do PRN suctioning in that area, and those types of things. So your textbook has a great care plan area that talks about teaching for patients that have had permanent trachs. So make sure you take a look at those pages. Let the patient also know safety issues such as sensory changes. Their sense of taste and smell will be altered, so make sure that they do have smoke alarms in good working order, because they won't necessarily pick up on the smell of smoke if that would occur. Other safety measures would be to prevent water from entering the stoma. So when that patient is showering, they actually have special waterproof bibs and devices that they can put over that stoma area to keep them from getting water in it. Also, when they go to get their hair cut or things like that, watch for hairspray aerosols, loose hair powders that could get into that stoma area. So they need to cover that and be very careful to wear a loose porous bib to keep those types of things from getting into their stoma. And they should wear some sort of a medical alert bracelet that would let someone know if they ever needed CPR and mouth-to-mouth resuscitation, that it needs to be mouth-to-stoma resuscitation, because mouth-to-mouth isn't going to help them at all. And to try and get them into support groups through particularly like the American Cancer Society, the American Speech, Language, and Hearing Association, and there's also an International Association of Laryngectomies, which would be an excellent support group for these patients.